A patient has a large arterial cannula in the right femoral artery for ECMO. The right foot is cool, pale, and the Doppler signal is absent. What is the most likely cause and immediate fix? A. Systemic hypotension, increase vasopressors. B. Cannula-induced arterial occlusion, insert a distal perfusion scratch/cannula. C. Venous congestion, elevate the leg. D. Embolism from the oxygenator, increase heparin. Answer: B. Cannula-induced arterial occlusion. Insert a distal perfusion scratch/cannula. Explanation: large bore cannulae in the femoral artery can physically block downward blood flow to the leg. A distal perfusion limb, DPL, must be placed to divert some of the ECMO return flow back down the superficial femoral artery to save the limb. During a routine check, you notice a small amount of flow, 0.2 liters per minute, going through the bridge of the ECMO circuit while the pump is running normally. What does this mean? A. The oxygenator is clotted. B. The bridge is inadvertently left open. C. This is a normal safety mechanism for the pump. D. There is a leak in the arterial line. Answer: B. The bridge is inadvertently left open. Explanation: the bridge connects the arterial and venous lines for priming or emergency weaning. If left open during active support, it creates a massive shunt where oxygenated blood goes straight back into the venous line, effectively bypassing the patient. It should always be clamped during support. You suspect the oxygenator is failing. You measure the PO2 entering the oxygenator, pre-O2, and the PO2 leaving it, post-O2. Which finding confirms oxygenator failure? A. Post-O2 is greater than 400 mm of mercury. B. Pre-O2 is 40 mm of mercury. C. Post-O2 is significantly lower than predicted for the current FIDO2. D. Post-O2 is equal to pre-O2. Answer: D. Post-O2 is equal to pre-O2. Explanation: if the oxygen levels before and after the membrane are identical, zero gas exchange is occurring. This is a dead oxygenator that requires immediate replacement. When using a vacuum to assist venous drainage in a closed-bag system, the pressure gauge suddenly reads -150 mm of mercury. What is the most immediate risk? A. Air embolism and hemolysis. B. Hypertension. C. Overoxygenation of the patient. D. Pump head decoupling. Answer: A. Air embolism and hemolysis. Explanation: excessive negative pressure, suction, can cause cavitation or pull air through microscopic gaps/stopcocks. It also physically traumatizes red blood cells, leading to hemolysis. A patient has a fibrinogen level of 800 mg per deciliter. How does this affect your ECMO troubleshooting strategy? A. It decreases the risk of clots. B. It increases the risk of wetting out and delta P elevations. C. It improves gas exchange efficiency. D. It necessitates decreasing the heparin dose. Answer: B. It increases the risk of wetting out and delta P elevations. Explanation: hyperfibrinogenemia, common in COVID-19 or sepsis, leads to rapid fibrin deposition on the oxygenator fibers. This increases the pressure gradient, delta P, and may cause the oxygenator to fail much sooner than the typical 14 to 30-day lifespan. On a chest X-ray of a VV-ECMO patient, the tip of the drainage cannula is in the mid-IVC and the tip of the return cannula is in the mid-SVC. The patient's SpO2 is 75% despite 100% FIDO2. What should you do? A. Move the cannulae closer together. B. Move the cannulae further apart, increase the gap. C. Switch to VA-ECMO. D. Turn off the sweep gas. Answer: B. Move the cannulae further apart, increase the gap. Explanation: if the exhaust of the return cannula is too close to the intake of the drainage cannula, the oxygenated blood is simply recycled through the machine. Increasing the distance between the tips, usually ensuring one is in the IVC and the other in the SVC/RA, reduces recirculation. In VA-ECMO, the pump RPM is high, but the flow, L/min, is lower than expected. The venous pressures are normal. The patient's systemic BP is 140/90 mmHg. What is the most likely reason for low flow? A. Hypovolemia. B. High systemic vascular resistance, afterload. C. Left ventricular failure. D. Clotted venous cannula. Answer: B. High systemic vascular resistance, afterload. Explanation: centrifugal pumps are afterload dependent. If the patient's blood pressure is very high, the pump must work harder to push blood into the aorta. Lowering the systemic vascular resistance, SVR, with vasodilators will often increase the ECMO flow. Shortly after starting VA-ECMO, the patient begins coughing up massive amounts of pink frothy sputum. What is the likely cause? A. The ECMO flow is too low. B. Left ventricular distension and pulmonary venous congestion. C. Oxygen toxicity. D. Heparin-induced thrombocytopenia, HIT. Answer: B. Left ventricular distension and pulmonary venous congestion. Explanation: if the LV is not vented and cannot pump against the ECMO afterload, the blood backs up into the lungs. This causes acute, severe pulmonary edema. You are about to give a unit of PRBCs to an ECMO patient. Where is the safest place to infuse the blood? A. Into the premembrane port of the ECMO circuit. B. Through a peripheral 4. C. Into the arterial return line. D. Directly into the pump head. Answer: B. Through a peripheral 4. Explanation: while blood can be given via the circuit, giving it through a separate 4 or central line is generally preferred to avoid introducing small aggregates or clots directly into the oxygenator fibers, which could increase the delta P. During a VA-ECMO weaning trial, the flow is reduced to 1.5 liters per minute. The patient's SpO2 drops to 50% and MAP drops to 50 mm of mercury. What does this indicate? A. The patient is ready for decannulation. B. The patient is not ready, native cardiac output is insufficient. C. The oxygenator is failing. D. The patient needs more sedation. Answer: B. The patient is not ready, native cardiac output is insufficient. Explanation: a drop in MAP and SpO2 when ECMO support is turned down proves that the patient's heart cannot yet meet the body's metabolic demands without assistance.